All right, welcome everybody. Today I want to introduce Dr. Neel Shah. He is a board certified orthopedic surgeon specializing in minimally invasive spine surgery. Dr. Shah is on staff at NYU, but is in private practice at New York Center for Spinal Disorders. And you have locations on the Upper East Side and in Flatiron, right?
Yep.
So, super excited to talk about basically a really hot topic is the difference between and the indications for cervical fusion and cervical disc replacement. So let's talk about the pros and cons, the clinical indication, the subjective and objective presentation of a patient that may be a candidate for one or other, or perhaps both, and why you would choose one versus the other. So I'll let the expert take it away. So just yeah, tell us a little bit about the differences and the benefits of disc replacement.
Thanks, Matt. Thanks for having me today. I'm really excited to talk about disc replacement. I think disc replacement is an amazing advancement that we had in spine surgery over the last 5 to 7 years. First of all, why can we do a disc replacement, or what do we look for in a patient that needs a disc replacement? A lot of the times, a patient that's been indicated for cervical fusion is a good candidate for disc replacement. And there's many reasons of why you would choose one or the other. Some typical presentation patterns that would lead a patient to get a disc replacement would be the same thing as a fusion. Either they have neck pain with radiating arm pain, like kind of like sciatica before your arm because you have a pinched nerve in your neck. And then other reasons would be not only is a nerve pinched in your neck, but your spinal cord is being pinched in your neck, which we call myelopathy. And those are all indications for getting a disc replacement versus a fusion.
Yeah, great. So, is there anything that would like kind of drive you more toward a disc replacement for a certain patient population, or do you feel that disc replacement should gradually overtake fusion as kind of the gold standard in treating, radiculopathy and myelopathy in the indicated within indicated parameters?
That's a great question. So, in my hands, I will try to put disc replacement in everyone. I think if we go back historically, when disc replacements first came out on the market, closer to about 10 years ago, the indication was a young patient with a very plump or a tall disc with a soft disc herniation. As we've seen over the last 10 years, surgeons have become a lot more aggressive. When I look at my practice from 10 years ago till now, I've also seen myself becoming a lot more aggressive in doing disc replacements on just about anyone who's a candidate for it. There's a couple reasons of why you can't do a disc replacement and you have to do the fusion. Some of those are, the biggest one really is, are your facet joints arthritic? What does that mean? So when we look at the spine, and we look at a spine segment, right? You talk about C3-4, C4-5, that's a bone, a disc, and a bone. Those segments, the way I look at them is you've got the disc in the front and you've got two little facet joints in the back. I like to equate it like a big wheel, like a toddler's big wheel. You've got the big wheel in the front, which is your disc, and you have two little wheels in the back, which are your facet joints. And those are what gives stability to that spinal segment, which is the C3-4, C4-5, C5-6 that we talk about so commonly. Now, if the disc itself is bad and herniated and degenerative, I can replace that with a disc replacement and put a new wheel in. If the facet joints are also arthritic, we don't have the technology yet to put in new facet joints or new little wheels in the back. And that's when we have to really think about fusion. Other indications for fusion, which we don't encounter as much, are if the patient's had bad trauma and has had a fracture to that segment, or infection or tumor or things like that. But in 90% of patients that I see, or maybe even closer to 95, that have been told they need a fusion, I can usually get a disc replacement into them, and they do quite well.
Yeah, that's a great point. And I think what I would probably recommend, from a physical therapy perspective, is that a physical therapist encourage their patients to seek out additional consults. If someone's recommend a fusion, talk to a minimally invasive surgeon who's done a lot of disc replacements. Surgeons is a whole nother soapbox topic that I'm sure Dr. Shah will talk about, but surgeons who do a lot of fusions like to do fusions. Surgeons who do, and if they only do a few disc replacements, they're probably going to lean toward fusion. If you have an expert who really does a ton of, disc replacements, they're going to be a lot more comfortable recommending disc replacement. So it's always good to just get that consult. And of course, you want to make sure there's good bone stock, there's no arthritic change. And I think that's what you're saying with the aging population. You're more likely to potentially have bone stock issues or arthritic changes but that doesn't mean that you still couldn't be potentially a candidate for a disc replacement, it's important to check out if a specialist thinks that you have a spine or a presentation that would be benefit from a disc replacement.
Yeah, and a little caveat I like to talk about is like I said, 10 years ago when I started doing these in the beginning of my career, I follow those rules. I have plump disc, young patient, soft herniation. My new indication is if I can get a knife blade into your disc, I can most likely get a disc replacement in there. And I've just seen my practice evolve over the last 9 to 10 years that I've been doing this now.
Yeah, I love that. And so, what are the benefits of a disc replacement versus a fusion?
And I think that is one of the reasons why I push disc replacement so high is that every outcome measure that we look at is better with a disc replacement. One of the biggest, well, two of the biggest reasons, one that kind of touches on what you guys do with motion and physical therapy is we can preserve your motion. When we do a spinal fusion, we're taking the disc out of existence and we're fusing the two bones together. So you're going to lose a little bit of range of motion with a fusion. Honestly, with a 1 or 2 level cervical fusion, most patients aren't going to lose enough motion to really make a difference, but you still are losing motion. And then the problem really comes into down the road. Now, if I'm taking 1 or 2 of your discs out of existence, so we're also taking your shock absorber out of existence, and there's less motion in your spine. So the discs above and below the levels that we've had to fuse now have to take on extra life or take on extra work. And we do know that there's a higher rate of needing more surgery after a fusion because the discs above and below will wear out faster, which is what we call in our world adjacent segment degeneration. Many research papers have come out. There was a great paper that came out in January of this year, which really looked at disc replacement versus fusion. And it really showed that in every outcome measure, in terms of motion preservation, lower operation rates, lower rates of adjacent segment degeneration, and much better functional outcomes, along with a faster recovery, disc replacement was far superior than fusion, and it was significant in all their outcome measures. The two downsides of that paper, the two kind of negative things that they talked about, which I don't really think affects me, is that disc replacement, they stated, had a longer surgical operative time. Again, in my hands, I've done so many disc replacements, it takes me just as amount of time to disc replacement than a fusion. And then there's a higher rate of heterotopic ossification, which is bone building around a disc replacement and kind of becoming a functional fusion. Again, I think that's device related. We can talk about that a little bit later. There are many different devices out there, and some of the techniques that you use to do the disc replacement can kind of counteract some of that as well.
Yeah, and that leads us to our next topic, which we're going to do a separate video with Dr. Shah about the actual surgical procedure, so you can tune in for that one. But we'll talk more about the actual procedure, the how the procedure is handled, what equipment we use, and we'll show some models there. But yeah, going back to these studies, it's they've been around for long enough for these longitudinal studies to come about, and to have reducing your adjacent segment degradation, is really going to help your longevity, your outcomes long term, which of course is the big issue with fusion. So more specifically with the younger population, right? So to really preserve, and from a physical therapy perspective, we always want to preserve mobility, and that's going to just allow you to have kind of a more pain-free movement and more active lifestyle. So that's a huge aspect. It's not just the near term. It's not just the recovery. It's not just the solving the initial problem. It's those long term, benefits you want to look out for now.
Agreed. Yeah, no, I've just seen patients just do better, not only in the short term, but definitely in the longer term with the disc replacement. Seeing X-rays of patients, 2, 3, 4 years out with continued motion at the disc replacement, it's an awesome thing.
Yeah, very cool. So just to kind of summarize, disc replacement versus fusion, and we kind of just like capture the big concepts here is that like the candidate itself may be very similar. You
Yeah.
may be able to choose a disc replacement or a fusion in any surgery. We recommend that you talk to multiple surgeons, and specifically if someone recommends a fusion, talk to someone who does a lot of minimally invasive disc replacements like Dr. Shah, and get that opinion on whether or not you'd be a really good candidate because the outcomes down the road could be good. You could have motion preservation, you could have reduction of adjacent segment disease. So all these elements really are benefiting you in the long term if you have disc replacement, and I think there's still a stigma, and a lot of people are scared of it, and because it could be relatively new, but it's not so new anymore. And understand that I always say this in all my videos: medicine is a business. So when you go to a doctor, and if they do a lot of something like fusion and they don't do a lot of disc replacements, they're probably not going to recommend it to you. So you are your advocate. You've talked to your physical therapist, talked to multiple surgeons, find what works best for you. And Dr. Shah is in New York City. I'll put his info below. So you can find him. Again, I forgot to introduce myself. I'm a physical therapist. I'm the founder of Equilibrium Physical Therapy on the Upper East Side. So these videos, I like to try to give the physical therapy perspective, kind of advising the patient because we're a very like we interact a lot with the patient, right, multiple times a week for a long duration, and sometimes it's up to us to guide toward doctors like Dr. Shah to make sure patients get where they need to go. So, any closing thoughts?
No, I think you kind of hit the nail on the head. I echo that. I think patients, you definitely build a long-term relationship with patients and can guide patients, and I totally agree. I tell all my patients to get a second opinion, even if they're like, I'm ready to sign up for surgery. I want them to feel like they're making the right decision and see their problem from a different viewpoint. And I agree. Surgeons, we like to do what we do. I like to tailor the treatment to the patient. So I like to find out about the patient. But as a surgeon, I see them maybe once or twice before we talk about surgery, versus you're talking about for them for a couple times a week. So you definitely know the patient better. And I agree, physical therapist and surgeon talking, I think that's a great thing. And keeping open lines of communication, which is great as well.
Yeah, perfect. So check out Dr. Shah's info below, and then we're going to do some other videos talking about, not just the surgical procedure. We're going to do another one on the rehab guidelines. What does it look like post-operatively? What does it look like post-surgery? And then another one on some questions. What do you ask a surgeon? Like how can you be your best advocate? So stay tuned for some more videos with Dr. Shah. But thanks so much for being with us today,
Thanks,
um,
man.
and we'll talk to you soon.
Sounds good.